A very good morning to all present. I am Dr. Vaibhav Agarwal, internal medicine resident from IPGMR Hospital, India. And I am going to present a case of hypovolemic shock in my patient, a 55-year-old male farmer by occupation, non-diabetic, non-hypertensive, euthyroid, non-smoker and non-alcoholic, presented with chief complaint of recurrent episodes of non-bilious vomiting, 10 to 12 such episodes, and intermittent loose stools, 2 to 3 episodes for the past 7 days. There was associated crampy abdominal pain, anorexia, fatigue, and nausea. However, there was no history of any fever, external blood loss, jaundice, weight loss, shortness of breath, oliguria or frothy urine, and any skin rash. The patient looked drowsy, had a pale look. He was apparently dehydrated with cold peripheries and a feeble pulse, having a blood pressure of 80 by 50 mmHg and a pulse rate of 124 per minute. On general survey, the patient was found to have moderate pallor, a Cushingoid facies, and bipedal edema. Rest of the systemic examination was apparently normal. At the emergency, the patient had an hyponatremia and hypokalemia, likely due to persistent diarrhea and vomiting. He was resuscitated with intravenous fluids via 2 wide-bore IV cannula, along with intravenous proton pump inhibitors and antiemetics. After initial stabilization, on further probing, it was noted that the patient has had bilateral knee osteoarthritis for the past 12 months, for which he had been taking over-the-counter NSAIDs and steroids for the past 10 months. He had pruritic polygonal annular lesions over bilateral thigh, suggestive of tinea cruris, for the past 8 months, and yellowish and greenish discoloration of his nails, suggestive of onychomycosis. He had 2 to 3 episodes of persistent recurrent diarrhea for the past 3 months, and this had aggravated over the past 1 week, with which he presented to us at the emergency. Initial investigation in the background of concurrent long-term corticosteroid use, along with hypotension, tachycardia, and diarrhea vomiting, a possibility of acute adrenal crisis was suspected, for which a 8 am serum cortisol and ACTH was sent, but it turned out to be normal. Routine baseline investigation showed an anemia of 8.6 with normal MCV, a high red cell distribution with of 32%. Iron deficiency anemia with low ferritin levels and low vitamin B12 levels was found. Total protein was also markedly low with low albumin and globulin. In this background of chronic persistent diarrhea with dimorphic anemia comprising of iron and vitamin B12 deficiency, along with decreased total protein and hypocalcemia, a syndromic diagnosis of malabsorption enteropathy was suspected, for which anti-tissue transglutaminase antibody was sent, but it turned out to be normal. So as of now, we have a 55-year-old male with nausea, vomiting, chronic diarrhea, intermittent abdominal pain, having abused chronic steroid for arthritis, and acute worsening of condition, showing moderate pallor, a Cushingoid facies, bipedal edema, anasarca, along with onychomycosis and tinea cruris. Investigation had revealed dimorphic anemia, hyperproteinemia, hypocalcemia. The urine examination was normal, and so were the chest X-ray and the abdominal ultrasound. The possibilities which we had ruled out as of now included adrenal crisis, celiac disease, any sort of pancreatic abnormality, HIV, any diabetic complications, any malignant etiology, or any drug-induced malabsorption. The eureka moment for us arrived when, after 2 failed repeated comprehensive stool examination, the third one showed us the morphology suggestive of Strongyloides stercoralis in the stool microscopy examination as shown. We did a CT enterography which showed multiple hyper-enhancing skip lesions involving the duodenum and jejunum. Upper GI endoscopy and D2 biopsy showed blunting of villi with villus atrophy. Ileocolonoscopy and biopsy showed lymphoplasmacytic infiltrate along with eosinophils, and larvae resembling strongyloids identified within the crypts as shown in the duodenal and the colonoscopic biopsy. So we had a diagnosis of a bilateral knee osteoarthritis followed by over-the-counter steroid abuse, patient having onychomycosis and tinea cruris, leading to chronic malabsorption, protein-losing enteropathy, giving a final diagnosis of Strongyloides hyperinfection syndrome. The patient was given ivermectin 12 mg once daily after meal for 14 days, terbinafine 1 year for onychomycosis, and orthopedic referral for total knee replacement. There was marked improvement in vomiting, diarrhea, repeated stool cultures became sterile, anemia and anasarca regressed and completely resolved at 6 months of follow-up. Our case analysis showed a farmer probably having asymptomatic chronic strongyloides infection. He used long-term steroid which significantly reduces immunity. This led to rapid multiplication, hyperinfection syndrome, led to mucosal erosion, malabsorption, manifesting as anemia, anasarca and diarrhea, resulting in hypovolemic shock with which the patient presented to us. What we learned from the case is that despite emerging rapid diagnostic tests like PCR, comprehensive and meticulous stool examination remains an inexpensive and gold standard diagnostic modality for parasite infection. Repeated stool examination at least three times must be emphasized due to intermittent nature of secretion of larvae. Rampant overuse of steroids, the single most important factor along with HIV, is mostly responsible. Age-old concordance of eosinophilia with parasitic infection is surprisingly absent, mostly due to steroid intake. Most patients undergo necessary radiological investigation before a diagnosis of strongyloides is made, highlighting the importance of stepwise protocol-based approach. Strongyloides comprises 75% of the 30 to 100 million cases worldwide in the Asian African subcontinent, mostly misdiagnosed due to poor clinical imitation with other conditions. Here is a case report showing a similar condition. Thank you for your patient listening.
Wow, great presentation. We have few questions, but we have, I think, Professor Paul to comment first.
Thank you, Dr. Vaibhav, for your nice presentation. This is basically a very eye-opening case, particularly for the physicians practicing in the tropical countries. This is one of the neglected tropical disease because prevalence not very less, but awareness, even we physician from tropical countries is less. But importance of this case is if you suspect because strongyloides can present with some mild acute symptom, can present with chronic infection, and can present with disseminated and hyperinfection syndrome. That is the most importance. And very important three feature: one lung symptom, GI symptom, and skin lesion. If you suspect three things, and the patient, the person has some exposure with the bare food, particularly in the soil, paddy field, agriculture worker, you have to suspect more that patient may have strongyloides. And very important, this is the only worm infection where you will not get usually the eosinophilia. Because in all over the world, the use of the immunosuppressive drug is increasing, particularly the liver transplant, kidney transplant, heart transplant is increasing number in India and surrounding countries. So this is becoming very important. And hyperinfection syndrome, that is the main issue why the patient present with such a this type of, usually in the roundworm and hookah we do not get such a hyperinfection syndrome, or patient don't present with shock, but here can present with shock. That is the very important eye-opening for the tropical physicians. Thank you, sir.
Thank you both. Questions? Yep.
So you didn't show the blood eosinophil counts, but as I understand, they must have been normal, correct?
Sorry?
The blood eosinophil counts must have been normal?
Yeah, blood eosinophil count I had showed, it was normal, it was 4%.
Sorry. Okay, so one explanation was the fact that the patient was taking corticosteroids, but there are other potential explanations in a patient who would have a hyperinfestation syndrome and who would have normal eosinophil counts and shock. Do you know what that other explanation could be?
Because the patient had taking long-term corticosteroid and there was abrupt withdrawal of steroids, so we considered a possibility of acute adrenal crisis because it might be precipitated, but the cortisol and ACTH were found to be normal in this particular case.
So if I may, there's an additional explanation, which is when there's hyperinfestation, these parasites really erode the mucosal surface in the digestive tract, and there's bacterial translocation. And these patients die sometimes of repeated gram-negative bacteria septicemia. It's pretty classical. Yeah.
We did the blood culture, but it was negative, so that was down the list, actually. Thank you.
Thank you for this nice presentation. Just I wonder his platelet and peripheral blood smear, because below in hemolytic anemia and the picture?
No hemolytic anemia was found. Bilirubin was also normal, and so was the reticulocyte count, and only peripheral blood smear showed anemia only with dimorphic pattern.
Can I ask what the role of antacids and PPI were here? So you gave intravenous PPI at the beginning, and then you said long-term management of antacids. But most of us would consider those contraindicated in enteric infections. So is there a specific reason why those were indicated here?
No, we just gave it because the patient was having drug, we just gave it for a 2 week, not for a very long duration, because patient was having some sort of dyspepsia and all. It was just a part of the conservative management, nothing specific, and it was only for a short duration of time.
Okay, thank you.
Well, 100 million people with strongyloides, and I don't think we ever diagnosed it. I suspect quite a bunch of people we missed then. Thank you very much.
Thank you.
Thank you, and